Hi, my name is Taylor Ellingson, and I'm going to be giving a presentation on chyle leaks, especially with the monitoring and different interventions. So just to give you a brief outline, first we're going to talk about some background information. What is chyle? What are the causes? Some diagnostic identifiers, medical treatment, and then specifically going into the nutritional goals, interventions, and how to monitor the response. So just to start off with some background information, the lymph system is what we're primarily going to be looking at. So it does have the immune system type of role. It helps with the absorption of excess interstitial fluid and its return to the bloodstream, and the transport of long-chain fatty acids and fat-soluble vitamins. Next, I would like to talk about fat digestion because chyle is primarily made up of fat. And so just to give you a brief overview, as food is ingested, lingual lipase, which is the secretion from your mouth, begins to work on the food. Once it goes into the esophagus and down towards the stomach gastric lipase continues to work on this breakdown. As fat moves into the intestine, bile salts are released and act as an emulsifier. So this would allow the hydrophobic fatty acids to be digested in the water type of liquid or environment. The interaction of bile, fatty acids, and unhydrolyzed glycerides form micelles. Micelles transport fatty acids and monoglycerides to the intestinal villi. Once the monoglycerides and fatty acids are absorbed, they are then resynthesized into triglycerides, combining with fatty acids, cholesterol, and protein to form these chylomicrons. The chylomicrons enter the lymphatic system, which then we would refer to that as chyle. So what exactly is chyle? Well, it contains mostly fat, like I had mentioned before. It also has a significant amount of protein, electrolytes, lymphocytes, and many other substances. It has an electrolyte concentration comparable to plasma, so just to give you a reference with that. If a large volume is lost, which you may see with many patients, it is rare, but you might see with some patients that you have in the hospital, it could result in electrolyte imbalances. So this could be hyponatremia, hypochloremia, as well as hypoproteinemia. They may also have malnutrition and immunosuppression. It can cause damage by compressing surrounding areas. So I had one patient, they had a chyle leak around their stomach area, and we then had to put tubing so that it could be put into a draining bulb so that it wasn't compromising their GI system. Chyle, there is about 2 to 4 liters produced each day, and it could range from 1 milliliter if you were fasting, or up to 200 milliliters per day following a high-fat meal. So it really depends on what you're eating throughout the day. Leakage is very uncommon. I think I've only seen 2 patients that have gotten a chyle leak before, and my preceptor said that it was very uncommon to have that happen in 1 week. So what are the different causes? Well, chyle leaks are very rare, but are difficult to manage, and that's because there isn't a lot of MNT or different types of medical treatment that they have found that specifically helps cure these chyle leaks. The mortality rate ranges from 0 to 50%. There are low outputs and high outputs. If it was low, it's less than 500 milliliters per day, and if it's high, it's greater than 500. Chyle leakage has shown to cause significantly longer stays in the hospital, and that may be due to the fact that they're not able to figure out how to manage it efficiently, or they may have some type of surgery that needs to be healing, so the healing process may take a bit longer. So where it typically occurs is in the thoracic cavity, the abdomen, around the heart, or as external draining fistulas. The primary cause is congenital lymphangiectasia, which is the lymph vessels are being dilated in the lungs. Secondary causes are malignancies, postoperative complications, and so forth. With the diagnostic identifiers, so with clinical signs and symptoms, the chyle leak will appear white and sort of like milk. It can also look clear, and that would mean that there's no fat in the chyle leak, or it may appear reddish brown, and they may have some red blood cells in there as well. If you were to test someone's blood, the triglyceride level will be greater than 110 milligrams per deciliter. If it ranged between 50 to 110, they will need a lipoprotein analysis just to make sure that it is chyle, or it might be something else that may be leaking. Typically, it's recognized within 5 days post-operative. A lot of them range from either 4 to 10, but this is kind of where they found like the middle ground of when it was typically diagnosed. Chyle leakage can increase with any type of activity. So that could just be walking around, it could be coughing, or it could even be someone eating food, which causes the stomach and the intestines to move. So there's a lot of studies kind of trying to figure out if we should do more TPN feeding or if they should just kind of eat an oral diet. There really is no certain way of what they found out, but we'll get more into that towards the later part of the presentation. One study found that despite a period of gut rest, leakage did occur. However, it was during a period of early feeding. So this led to the recognition that leakage was an earlier stimulation of the lymphatic draining. So they found out that if someone were to eat right after surgery, it may increase the chyle leakage. Early recognition is key when trying to treat this type of diagnosis. So with the medical treatments, you could start off with pharmacological treatment, drug therapy to reduce the lymphatic flow, surgical repair to seal the repair that has been done. Otherwise, some other things that I've seen done is compressive dressings, bulb suctions, as well as bed rest, just to decrease the activity and making sure that we are draining the fluids out so that it's not compromising anything inside of the body. Now, going into nutrition, the nutritional goals really is prevention. I don't know if there's a certain way that dietitians or other health professionals can kind of prevent this from happening, but this is one of the key things in articles that I've read. That is the best way to kind of manage a chyle leak. We want to decrease the production and flow, and this may be due to, or this may be helped with eating less fat or just decreasing your overall food intake. We want to make sure they're replenishing their fluids and electrolyte losses, preventing malnutrition, aid in maintaining or replenishing nutritional status. Evidence to suggest that nutrition may have a role in the management, but like I said, there isn't evidence that is sufficient to determine which methods are more effective. So with some of the nutrition interventions that have been done before is doing a low or fat-free diet. And later in a few slides, I'll talk about what a lower fat-free diet may look like. We want to encourage small, frequent meals to ensure the patients are getting adequate calories because, as you may know, fat contains a lot of calories compared to the other macronutrients. So if we're cutting these out, we want to ensure that they're getting enough calories throughout the day to support their healing needs or whatever may else be going on. Supplementation of essential fatty acids and fat-soluble vitamins may need to be introduced. Ensuring that protein needs are met for the healing process, like I mentioned. And if on a low-fat diet for more than 2 weeks, you may need to supplement with medium-chain triglycerides, which we'll get more into detail later. And lastly, if needed, they also may need to feed via enteral nutrition or parenteral nutrition. This area is still being looked at, and many research studies are trying to be done to see what they can do, but I thought I should touch up on this as well, as it may be more current research being put out there. So with a low-fat diet, like I said, chyle contains mostly fat. This component should be part of the first-line therapy along with drain suction and pressure dressing. So if you're putting less fat into the body, the chyle is going to output less than what they typically would be on a regular diet. It's possible that increasing chyle output from dietary fat may impair the lymphatic vessel healing. So what that means is that if we're putting fat through the body and it has to go through the lymphatic system, it's going to focus more on that rather than healing. So if we're able to kind of cut out fat for a little bit or just make it less than what they would usually eat, it's going to have them heal better. So what's considered low fat? Well, fat-free would be less than 0.5 grams per serving. Recommendations around 20 to 25 grams per day have been shown to improve chyle leaks through research, but what I've seen is they have the best results at 20 grams per day. So if you think about it, a typical meal sometimes may be up to 15 grams of fat. So really, it is a very small portion of fat that they're eating throughout the day. And we'll kind of go through some foods that they're able to eat and some foods that you may want to reconsider. Once they are on this 20 grams or 25 grams of fat per day, you want to make sure that they're spreading them out throughout the whole day versus one meal, because it may be hard to find foods that they would like that contain no fat for the rest of the day. So looking at some of these pictures, it shows the different food groups, what foods are recommended for the chyle leak program, and some types of foods to avoid. Towards the bottom down here where it says the products, these are different types of products that are in hospitals that a person who has a fat restriction diet may want to include in their breakfast. The egg beaters, they're contain less fat, or there's different types of supplements on the bottom that if they're not able to get enough calories throughout the day, we can add these because they're higher calories and lower volume. Essential fatty acid supplementation. So deficiencies may occur on a fat-free diet in 2 to 4 weeks if they're on this diet for that long. So some signs and symptoms of essential fatty acid deficiencies may be skin lesions, eczema, impaired wound healing, etc. You can get essential fatty acids through oils such as sunflower, olive, soybean, or even corn oil for easier access. Otherwise, if they want to eat more of a food-based diet, they could introduce foods such as fatty fish, nuts, or seeds, but you want to ensure that they're not exceeding the 20 to 25 gram fat limit. So with these oils, it's just an easy way to get it through their diet. And if you didn't know, essential fatty acids are the linoleic or the linolenic acid, also called as omega-6 or omega-3. With their protein requirements, it really depends on the patient's circumstances, but you would typically account for injury or surgery-related intake when determining how much protein they need throughout the day. You may need supplementation to meet these needs. So like I mentioned, there are some fat-free supplementations, such as Ensure or Boost Breeze, and this will help reach their calorie requirements. Intake should account for losses if an external drainage is present and for wound healing. So the Kyleak contained fat and protein, so if they have a high output, we want to make sure that we're replenishing them with enough protein as well as calories. With MCT supplementation, dietary fat ingestion may impair the healing of the lymphatic vessels, so MCT supplementation may be valid. But is there sufficient evidence? Not exactly. Like I said, there's ongoing research about this topic, but they have seen that MCT oil does help with Kyleaks and help get their fat requirements in throughout the day. So like I said, it's needed for fat requirements, but it does not contain essential fatty acids. So if you were to introduce MCT oil, making sure that they are getting their essential fatty acids through a different source is key. What is great about MCT oil is that it doesn't require the transport of the lymph system. It kind of bypasses that. So it won't cause any disruption of healing or any other damaging effects. It is water soluble. And if you were to take a large dosage of MCT oil, steatorrhea may occur, and that's just fatty stools. The larger amounts of MCT decrease the absorption of the long chain triglycerides, which is what will be a result if you're having a high amount of MCT oil throughout the day. So the recommended dosage is about 4 to 6 tablespoons, and we recommend spreading that out throughout the day and not just putting it in all at once. I've also heard that MCT oil does not taste very good, so if you're able to mix it in with different kinds of foods or beverages, it may help it go down easier. If you were to have a higher dosage of MCT oil, some symptoms may include cramping, distension of the stomach, nausea, emesis, bloating, diarrhea, etc. So now going on to some fat-soluble vitamins. So these are also carried by the lymph system. They do become problematic if limiting fat intake, because in order for these vitamins to absorb, they need fat. So if we're reducing the amount of fat that we have throughout the day, it's going to be really hard for these to be absorbed. Many of the research articles that I've seen, they wanted the patients to do a multivitamin with minerals because they are on such a strict oral diet that if they're not able to get the adequate amount of food throughout the day, this will kind of compensate for that. There are water-soluble forms of fat-soluble vitamins, which I didn't know, but there are some forms that may be recommended if the patient isn't able to get these in through food or supplementation. Some other research articles, they talked about conservative therapy. So what this means is that there's non-suction drainage. It's a low-fat diet and compression on site with drainage that is less than 500 milliliters per 24 hours. So a lot of them like to start off with this, and then if they don't see any improvement, they go more towards a strict type of therapy. So with high output fistulas have shown to respond unsatisfactorily alone and require some surgical interventions, which would be more of the higher up type of therapy. So now with the TPN, I'm just going to go through some studies and kind of show you what they said about each, how each patient managed their chyle output with TPN. So one study talked about Kyleak after an esophagectomy, and all were initially managed with TPN and no enteral intake. Study 2, it was just a literature review. They saw that if a low-fat diet isn't working, the patient can be put on NPO for 24 to 48 hours to manage the leak. And so, like we have said before, if they're not having fat coming in through their system, the chyle leak output may be reduced. So what they saw is an improvement after 48 hours NPO. If needing to reinitiate feeding, they began with TPN as it resulted in a better, more effective diet strategy. And this may be because they are kind of bypassing the whole GI system, but they're still able to get enough calories and protein, whatever they need, through TPN. They may introduce octreotide, I don't know how to say that, sorry, as it reduces gastrointestinal production of chyle. So it reduces the blood flow and decrease in gastric, biliary, pancreatic, and intestinal secretions. So this kind of goes hand in hand with the activity. If there's less activity, there's less chyle output. Study 3 was dealing with the pancreas, or pancreatic duodectomy. They started patients on TPN until the leak had clinically resolved and the patient had tolerated enteral nutrition for a period of 24 hours. And they found that TPN was used about 10 to 11 days. And the last study, number 4, it was just a literature review again, and it suggested that TPN should only be used when oral intake is contradicted. So it's kind of going the opposite of what other studies have been saying. And I know with clinical nutrition, we want to avoid TPN as much as possible and start with an oral diet and then go to enteral nutrition. But with these types of patients, maybe TPN would be the best recommended situation for them, because it would essentially bypass the GI and decrease the activity overall. So TPN has shown to work because it gives the bowel a rest and reduces the chyle output. And next, with the monitoring the response, we want to make sure that there's a decrease in drainage volume, decrease in size of the effusion, and that could be through X-ray, decrease in abdominal girth, or decrease in frequency and volume of the chyle leak. Next, we want to make sure that the micronutrients are being met, because there is a loss of fluid and electrolytes within the chyle, and it's very common. If we're able to, we want to compare the response to baseline parameters. So really looking at the amount of drainage, different X-rays if that was applicable, or abdominal girth. We also want to make sure that the patient is maintaining good nutritional status. So going back into making sure they're getting adequate calories and protein and really staying on that restricted fat diet. All right, and that concludes my presentation. Thank you.